Hello and welcome everybody. Welcome to the approach series. Today we'll be discussing about the approach to dizziness and vertigo. In the very beginning, I would like to tell you this slide has taken from the Osmosis website, and without further delay, let's get started. So, first of all, we'll have to um, differentiate in between dizziness and vertigo. If a patient comes to you with no complaining abnormal sensation of motion, such as spinning, tilting, sinking, he has no such sensation, but he has this uh, symptoms: lightheadedness, altered spatial orientation, faint, but no abnormal sensation of motion, no spinning, no tilting, no sinking. Uh, but patient has off balance, may be nauseous or vomiting, may or maybe not gait impairment, but no nystagmus. So if I break it down, in dizziness there must be two no abnormal sensation of motion and no nystagmus. If these two are present, then simply it's not dizziness, it's a vertigo. So first we have learned how to differentiate in between dizziness and vertigo. Now how to approach in dizziness. So first of all, we'll ask the question to differentiate whether it's episodic or it's a persistent dizziness. If it's an episodic one, then we have only two diagnoses, that is orthostatic hypotension and panic disorder. In orthostatic hypotension, the patient will be complaining dizziness with sitting or standing up, may complain about a racing heart, about to pass out, or like vision darkening. Patient will give history of recent volume depletion, like vomiting, diarrhea, or blood loss, or some certain neurological disorders such as Parkinson's disease, multiple system atrophy, neuropathy. And on physical examination, in case of orthostatic hypotension, we'll find systolic blood pressure drop greater than or equal 20 milligram mercury, or diastolic blood pressure drops more than or equal 10 millimeter of mercury with standing. We may found prolonged capillary refill time or pallor during episode. Another episodic dizziness is panic disorder. Intense episodes of fear, discomfort, peak within minutes, with shortness of breath or chest pain sometimes. On physical examination, sometimes we can find diaphoresis, tremorlessness, and definitely a tachycardia may present. So in such cases, we can call it a panic disorder. If the dizziness is a persistent one, we have two diagnoses. One is medication side effect and post-concussion syndrome. In medication side effect, mainly antihypertensive and antihistamine, these two drug causes dizziness. On history we'll find the patient will tell like starting off a new antihypertensive or antihistamine medication, or maybe the dose has increased. On the other hand, in post-concussion syndrome, patient will give history of recent trauma. With that, may complain of headache, sleep disturbance, mood change, impaired attention or memory, cannot remember the things. On physical examination, we might found abnormal cognition or focal neurological deficit. Let's say uh, any disruption of the function of the brain. So these are the dizziness. So in a nutshell, dizziness, first of all, to know, no abnormal sensation of the motion. Okay, and the second one, known stigmas, but patient complains of lightheadedness or altered spatial orientation, off balance, gait impairment, nausea, vomiting. So it's a dizziness, and whether it's episodic or persistent, it's an episodic one. Then orthostatic hypotension or panic disorder, either one. If it's a persistent one, either it's effect of medication or it can be post-concussion syndrome. If there is abnormal sensation of the motion or nystagmus may present, then if patient complains of abnormal sensation of the motion, then it's a vertigo. And in vertigo, we will find almost every symptom except that two. With that two, no, we have we had on dizziness, like off balance, nausea, vomiting, gait impairment, and definitely that here you might get nystagmus as well depending on the condition. So for the vertigos, do the same, whether it's episodic or the persistent one. If it's episodic, last few seconds, it has a triggering factor, then definitely it is a benign paroxysmal positional vertigo with no hearing loss and tinnitus. Well, listen, benign paroxysmal positional vertigo, it's a vestibular disease, so it has nothing to do with hearing loss, and it has a triggering factor. Okay, sorry, it has a triggering factor like triggered by head position and change. So here there will be no hearing loss because it's a vestibular disease. There will be calcification in the semicircular canal. So that is the culprit who is doing the disease. So that's why here we'll get no hearing loss or tinnitus, but we'll get a trigger factor, that is head position change, and it's a recurrent episode. When you move your head, you will get it, and it will last few seconds. If you still the head, if you keep head still, then there will be no vertigo. But if it's episodic, a recurrent episode lasts minutes to hour but has no trigger factor, your head is still but still you are getting it, the vertigo, with hearing loss or may not be tinnitus. It happens because of your endolymphatic system fullness. Okay, so your ear might feel pressure. In this case, we'll perform, in both cases, we'll perform Dix-Hallpike maneuver. In benign paroxysmal positional vertigo, we'll find it positive, but in case of the Meniere's disease, we'll get it negative. And if the vertigo is persistent, so consider acute vestibular syndrome. Here we'll be performing hints, head impulse test, and nystagmus, and test of skew. These terms are very difficult to describe here, so I would recommend you to watch some videos for head impulse test, how to elicit this test, and how to test of skew, how to perform the test of skew as well. So it's very difficult to describe it here. So if it's acute and new onset of vertigo and persistent, not stopping, then do hints, head impulse test, H for head, I for impulse test, N for nystagmus, T for test, and S for skew. So if head impulse test is positive with direction fixed opposite to the affected ear, direction fixed horizontal nystagmus, and the skew no vertical skew, then it's a case of acute peripheral vestibular syndrome. Acute peripheral vestibular syndrome. And if you rub the finger close to the ear, I mean no hearing loss, I mean if the patient can hear the rub, that means no hearing loss, that means vestibular neuritis, that means like in the vestibular nerve only the vestibular part is inflamed, so that's why there will be no hearing impairment. But if patient cannot hear, it's a labyrinthitis, that means the labyrinth includes both the part of the hair. So here you will get the hearing impairment as well. So if it's acute new onset of vertigo, hints, I mean head impulse test is negative, and direction changing horizontal or a vertical nystagmus, not direction fixed, direction changing horizontal or vertical nystagmus, and test of skew is a vertical skew present, then it's acute central vestibular syndrome. Perform brain MRI. If infarction or hemorrhage, brainstem or cerebellum is stroke, or multiple white matters lesion plus minus, I mean may or maybe enhancement, is a demyelination. So this is the procedure, this is the approach to the vertigo. So first ask whether it's episodic or not. If triggering factor, last few seconds, no hearing loss or tinnitus, benign paroxysmal positional vertigo. And if there is the golden triad, that is hearing loss, tinnitus, and vertigo, you go for the Meniere's disease. Definitely don't forget to perform this Dix-Hopike maneuver here. And if it's a persistent one, either it will be acute peripheral or acute central vestibular syndrome. How to differentiate? Just perform the Hens test. Just perform the Hens test. Just perform the Hens test. Persistent, perform the Hens test. If head impulse is positive and test of skew is negative and direction fixed horizontal nystagmus, acute vestibular syndrome. Peripheral has to rub the finger if patient is hearing, vestibular neuritis, or if patient is not hearing at all, labyrinthitis. And if Hens test comes otherwise, head impulse is negative, direction changing horizontal or vertical nystagmus, test of skew, vertical skew, then it's the acute central vestibular syndrome. Perform an MRI, so whether it will be stroke or demyelination.